Now, no matter how complex aortic stenosis seems, severity is based on three numbers. If you master these, you master aortic stenosis as a sonographer. Anytime we assess this pathology in echo, we're asking three simple questions. One, for velocity. How fast is the blood being forced through the valve? As the valve narrows, blood has to move faster to get through it. Higher velocity tells us the valve is more obstructed. Two, for gradient. How much pressure does the left ventricle need to overcome that narrowing? A higher gradient means the obstruction is more severe. Three, for valve area. This tells us the true size of the valve opening using the continuity equation. The smaller the area, the worse the stenosis. We never use just one measurement. All three should tell the same story before we assign severity. Let's talk about the first one, peak velocity, or what we call Vmax. As stenosis gets worse, velocity goes up. This is why the IAC recommends using a non-imaging continuous wave Doppler probe, or what we call the cutoff probe, and scanning from multiple windows. Remember, a peak velocity greater than 4 meters per second is associated with increased symptoms and mortality. To assess aortic stenosis velocity, we use continuous wave Doppler. This measurement is all about alignment, so we always chase the highest velocity. Start in the apical window. From the apical 5-chamber view, place your continuous wave Doppler cursor directly through the LVOT and the aortic valve. Make sure your Doppler line is as parallel to flow as possible. If the velocity looks low or if the envelope looks weak, do not accept it. Do not save it or store it. Measure it again. Move to additional windows. Check the apical long axis or apical 3-chamber. Take a look at the right parasternal window and check the suprasternal notch if needed. Now, this is where the cutoff probe comes in. The cutoff probe is a non-imaging continuous wave probe. It does not create a picture, but it gives you excellent Doppler alignment. Use the cutoff probe from the right parasternal window and the suprasternal notch or anywhere you suspect better alignment with flow. Because this probe has no depth limitation, it's often the best way to capture true peak velocity, especially in severe aortic stenosis. Record velocities from all windows and probes and report the highest peak velocity. Once optimized, trace the outer edge of the continuous wave Doppler envelope to obtain the peak velocity. Remember, higher velocity means greater obstruction across the aortic valve. Next, the second measurement we focus on is the mean pressure gradient. You should know that mean gradient is now the preferred gradient measurement. You trace the continuous wave Doppler envelope, start and finish at the baseline, and average at least 3 beats in a normal rhythm. Remember, Doppler measures velocity, not pressure. The mean gradient is calculated automatically by the ultrasound system once we trace the continuous wave Doppler signal. This calculation is based on Bernoulli's equation, which converts velocity into pressure. To get it, first obtain a well-aligned continuous wave Doppler waveform through the aortic valve using all available windows and the cutoff probe if needed. Once you have the tallest, cleanest envelope, trace the outer edge of the velocity envelope. Start at the baseline, end at the baseline. The machine will then calculate the mean pressure gradient for you. If the rhythm is irregular or if you want to be precise, average at least 3 beats. Now, just for understanding, let's talk just a little bit about the Bernoulli's equation. This is just a beginner-friendly explanation. Bernoulli's equation is simply a way for us to turn blood speed into pressure. We can't directly measure pressure with echo, but we can measure velocity. And velocity tells us how blocked, calcified, or tight the valve is. How we measure in echo. We use continuous wave Doppler because aortic stenosis creates very high velocities. Our goal is to align the Doppler beam as parallel to blood flow as possible. We never rely on just one window. We check multiple windows and use the highest velocity we can find. Now, This looks like a math equation, but it's very simple. We take the peak velocity, square it, and multiply it by 4. The machine does this automatically once we trace the Doppler envelope. Here's just a quick example. If the peak velocity is 4 meters per second, we square it, which gives us 16. Multiply that by 4, and we get a pressure gradient of 64 millimeters of mercury. A gradient this high tells us we are dealing with severe aortic stenosis. Even without the math, velocity alone gives us a strong clue. Once velocities reach 4 meters per second or higher, we are definitely in the severe range. Now, the third measurement we take is the aortic valve area. Remember this. In order to get the aortic valve area, the 3 things you need to get is the diameter in plaques. You do pulse wave Doppler of the LVOT, just below the valve. You do continuous wave Doppler through the aortic valve. This you'll have to use multiple windows for because you need the highest jet. Here's a short memory line for you when it comes to these measurements. Diameter in plaques, pulse wave in LVOT, continuous wave through the aortic valve. Now let's go through these one at a time. 1. Your LVOT diameter. This you acquire from plaques. The goal: measure the LVOT just under the aortic valve in mid-systole. Place the calipers inner edge to inner edge at the LVOT. Measure across the LVOT where it looks most circular. Save the still image with the measurement. Second, you need your LVOT VTI. This is your pulse wave Doppler. Your goal is to sample the flow in the LVOT. This should be laminar flow generally, and trace the envelope from the apical 5 chamber or the apical long or apical 3 chamber. Optimize the LVOT or aortic outflow. Turn on pulse wave Doppler. Place the sample volume or the sample gate in the LVOT just proximal to the aortic valve. Adjust the scale or the baseline so the pulse wave Doppler waveform is well displayed and not cut off. Record 3 or more beats. If the person has an arrhythmia or irregular heartbeat, record 5 beats. Trace the pulse wave envelope to obtain LVOT VTI. Save the clip or still image with the traced measurement. For this measurement, remember, if you're too close to the valve, you'll start sampling the stenotic jet, which is wrong. If you're too far into the LVOT, you'll receive weak or less accurate signals. 3. Your aortic VTI. For this, you need continuous wave Doppler. Your goal is to find the highest aortic jet velocity and trace the full envelope. Use continuous wave Doppler through the aortic valve from multiple windows, including the apical 5 chamber, the apical long axis or apical 3 chamber, the right peristernal, and the suprasternal notch if needed. In each window, align the continuous wave cursor as parallel to the flow as possible. Identify the aortic stenosis jet. It should be dense, high velocity, spectral signal. For patients with a normal EKG, record 3 or more beats. For patients with an irregular EKG, record 5 or more beats. Now that we've obtained the 3 measurements, let's gain some understanding as to how the aortic valve area and the continuity equation are utilized. Here's the core concept. The continuity equation is based on one simple idea. Flow in a tube is constant. The same amount of blood that leaves the left ventricle has to pass through the aortic valve. Why velocities increase? If the valve opening becomes smaller, blood still has to get through. When the area decreases, velocity must increase to maintain flow. That is why severe aortic stenosis produces very high velocities. What exactly does the continuity equation do? This equation uses measurements from the LVOT and compares them to flow across the aortic valve. From this, we calculate the aortic valve area, which tells us how tight the valve actually is. So let's talk about planimetry versus continuity. We can measure aortic valve by tracing the valve opening, which is called planimetry. However, heavy calcification and poor image quality usually makes planimetry inaccurate. This is why the continuity equation is more reliable and preferred in most echo labs. Think of it this way. Bernoulli tells us how fast the blood is moving. Continuity tells us how small the valve opening is. Together, they define the severity of aortic stenosis. Hopefully that was able to give you guys a short but good understanding of why we use both. When ejection fraction is normal, mild aortic stenosis has velocities under 3 meters per second. Moderate aortic stenosis falls between 3 to 4 meters per second. Severe aortic stenosis is anything over 4 meters per second with a mean pressure gradient over 40 millimeters of mercury and an aortic valve area under 1 centimeter squared. Always use multiple parameters, never just one. Remember, velocity is always meters per second, gradients are always millimeters of mercury, and valve area is always squared centimeters. If this helped you, subscribe so I can keep helping. Don't miss the next video.